Hi, welcome to Bites MD. Today we have here my good friend Dr. Stephen Fern, and he's also a distinguished colleague of mine. He is a specialist in gastroenterology, and he's also my co-worker. Although we work for the same health organization, we want to make this distinct and clear that this content of this video is not sponsored by them. It's created solely for educational purposes. Welcome.
Thanks for inviting me. I'm excited to be here.
So today our topic is eosinophilic esophagitis. It's a word.
Easy for you to say. I say it about 15 times a day. So eosinophilic esophagitis, very interesting topic, very new topic actually.
Correct. I haven't really read about it during my medical school day. Only during residency I kind of come across it once, and then here where we're working I've come across it quite a few times, and it can affect the quality of life of patients.
Yeah, most assuredly. So I mean the first real case of EOE. We'll just say EOE. EOE.
Yeah.
The first real case of EOE was in 1978. So it's really a relatively new disease, and it used to be a disease of children who had failure to thrive, who had nausea, vomiting. And then I had this about maybe 20 years ago. We started seeing all these eosinophils that the pathologists were seeing in the adult population. And now it's a pretty common entity, eosinophilic esophagitis. So we see it pretty commonly.
Yeah. I think I'm also seeing a lot more adult patients now as well. So a lot of times I think they present as dysphagia or chest pain, or sometimes very commonly just acid reflux. And it's so hard to distinguish it from a primary care standpoint.
Yeah, from the majority of adults present with either dysphagia symptoms or chest pain. And sometimes the first sign of eosinophilic esophagitis is actually a food bolus. They come into the ER and they've had problems for years, and then we scope them and they've got a real small caliber esophagus and food is stuck in there. So it used to be, we always used to think that reflux was with the Schottky's ring was the number one reason for dysphagia and esophageal food boluses. Now it's eosinophilic esophagitis.
Wow, interesting.
Yeah.
So what can we do? So you were saying this started back in 1978. So obviously something has changed in our diet or environment that we're developing EOE. What do you think that might be?
Yeah, I think it's allergy. I think now we are exposed to so many different allergens. I remember as a kid growing up, Scooter Willett, man, he'd always be the last one to finish his meal when we were eating. And I'm thinking back, he probably had eosinophilic esophagitis back then, but who knew back then? That was in the 70s. We started seeing all this eosinophilic esophagitis into the 2000s. And I think really it's related to all the allergy exposures that we have. And now we really know that it is really a food allergen, that's our esophagus, for some reason, no one really knows the real pathophysiology of it, is that the esophagus is exposed to these allergens, the 6 specific ones that we know from our 6-food elimination diet. We know that those are the ones that have the highest allergen, and it just brings these white cells, these eosinophils, into the esophagus and causes inflammation and stricture, and that's why the food gets stuck in there, and it really can be debilitating. People don't want to go out to eat because they're afraid food is going to get stuck. They can get chest pain, so it really is a problem with socialization, really.
Yeah. And just to clarify for the viewers that aren't aware what eosinophils are, they're a type of white blood cell that functions in response for parasitic infection, bacterial infection, and most importantly, for this topic, it functions as a inflammatory modular response and it's allergies, as Dr. Stephen Fern said. And when we're exposed to the allergies, they release a lot of these cytokines, chemokines, and interferons that causes this inflammation, that causes, I presume, the swelling and everything that food bolus.
So whenever we diagnose with someone with eosinophilic esophagitis, and that is really by upper scope, biopsy in the esophagus, specifically in the lower esophagus and upper esophagus, but I biopsy throughout. And you have to have 15 eosinophils per high-powered field. That's the cutoff. Because we can see eosinophils in other GI diseases, especially reflux disease, and that's why we like to biopsy in the upper esophagus. We can see eosinophils at the GE junction related to reflux, But we definitely, if they're up in the mid-esophagus, upper esophagus, it's likely eosinophilic esophagitis. Yeah.
When you do a biopsy and the eosinophils for a GERD patient, how many eosinophils are we seeing?
5 to 8.
5 to 8.
Yeah.
Okay. So 2-3 times a month.
Yeah, I scoped the lady the other day, and 120 eosinophils per high-powered field.
Yeah.
And there's a specific criteria that we use also when we're scoping. It's called the EREFs. This is probably beyond what we need to know, but I love talking about these things. So EREFs is a classification system that we use to tell other gastroenterologists what eosinophilic esophagitis looks like. So E is edema, R is rings, the other E is exudates, F is fissures, and strictures. So the EREFs are the things that we calculate to tell other gastroenterologists, hey, this is what this looks like. And so after we put people on medication or a 6-food elimination diet, we rescope them, and then we can see if the esophagus has responded and the eosinophils are down. So when we diagnose the people with EOE, they usually have somewhere atopic presentation. They have seasonal allergies, they got asthma, they've got psoriatic arthritis, they have some of these other allergic reactions, asthma. When they have those along with eosinophilic esophagitis, then we put them on medication. Usually it's a proton pump inhibitor to start because it's so easy to get. But people respond to that about 30-50% of the time. Then we kind of go on other things. But underlying is this inflammation that is related to food. And the 6 foods that we think about is cow's milk, soy, eggs, fish, nuts, and wheat. We all know about celiac disease, which is also associated with eosinophilic esophagitis as well. So those are the 6 foods that we eliminate early. There's many different ways of doing it. The majority of the time we'll eliminate all 6 of those for a 4 to 6 week period, and then rescope and see if the eosinophils are gone. If they are, then we slowly reintroduce them. Fish, nuts, eggs is in a specific order, and then the last one, cow's milk is by far the #1 allergen that we see. So we reintroduce. We used to do scopes after every addition, but now we just kind of follow symptoms that the patient has, whether it be dysphagia or chest pain. So the 6-food elimination diet is super important in treating eosinophilic esophagitis.
That's a really strict diet to go for about 1 to 2 months.
So the other diet that's recommended is an elemental diet. Talk about being strict, but so about 70% of people who are on a 6-food elimination diet will have success at eliminating the eosinophils, decreasing their sensation of chest pain and dysphagia. Elemental diet, which is all amino acids and no allergens whatsoever, they have about a 90% response rate. Now, as you all know, elemental diet is really not you can't follow elemental diet. It's not palatable, it's expensive, but much like FODMAPs for irritable bowel syndrome, that hopefully we'll talk about at another podcast. It's just a guideline. It's a guideline to show, hey, you are super allergic to shellfish, and you should stay away from that. So once we start bringing foods back in together again, then we go ahead and go, okay, you can tolerate fish, you can tolerate nuts, you can tolerate soy, but milk you cannot tolerate.
So you're on the 6-fed diet for approximately 2 months now, or whatever duration, and you've been scoped, everything looks normal. Now you're slowly reintroducing food. Let's say you reintroduce soy first.
Yeah.
Okay. How long are we waiting before we start to have symptoms?
In 2 weeks.
In 2 weeks.
Yeah.
So every 2 weeks we slowly just introduce one type of food and kind of see how it goes.
Exactly right.
And at that time, I presume you're not on PPIs and proton pump inhibitors such as omeprazole.
You can be.
Oh, you can be.
Oh yeah. We used to think that EOE was part of the GERD spectrum. We know it's probably not 100% that way, and that's when we started using PPIs. Once again, the proton pump inhibitors, Nexium was the one that. Nexium has a lot of data with eosinophilic esophagitis. That's the kind of one that the studies all use. Nexium BID. And so we used to put people on that for 8 weeks, see how their symptoms are, and then wean them off of it. and then use it kind of on an as-needed basis. Remember, this could be a seasonal thing too. It could be a tree, pollen, weed, grass. And so there are some people who have more problems in the springtime, more problems in the wintertime, whatever they're allergic to from a seasonal standpoint. So they can just use the PPIs on an as-needed basis only too.
So how does seasonal allergies affect the esophagus? Is this based on increased IgE in the body?
Right. Yeah. So there's an IgE portion of it, and then there's another portion of eosinophilic esophagitis that actually causes marked inflammation. You were talking earlier about the interleukins. Interleukin 13 is the one we think about mostly coming into the esophagus. And the more that purge of eosinophils, the increased risk we have of inflammation, which causes narrowing, and then eventually fibrosis. So people will have small caliber esophagus. So a normal esophagus is maybe $50 size. These people you can't get a standard endoscope down there with just 9 millimeters. So you have to go down there and stretch them open a little bit and kind of get the scope down there to look at the remainder of the esophagus before you can even start stretching them out. That's other treatments for EOE now, and we'll go down there and stretch it open with a little savory dilator or a balloon dilator, open things up. But we need to treat the underlying cause. And right now there's a new medication out. Can I mention?
Why not?
Okay. There's an injectable medication called Dupixent, which we use. It's a once-a-week injection. There's a new medication market called EOHILIA, EOHILIA, and it's actually a steroid slurry that they use twice a day. So as we're finding more and more about eosinophilic esophagitis, the new medications are coming out. We're actually going to have a study in our research group now for another drug for eosinophilic esophagitis. So it's new, but there's a lot of new data coming out about it.
And now, in terms of primary care physician, a lot of times we do not prescribe any of these immunomodulators. One, because we don't know much about them, and two, they're quite expensive. Sometimes insurance will not cover it from a primary perspective, and you need a specialist. So, the process of us treating before is usually starting with a 6-fat diet, PPIs. And what do you think about doing like steroid inhalers, like say, for example, fluticasone, or budesonide, just inhale through the mouth, or we can do like a nebulizer solution and just swallow that as well. What do you think of those?
So interesting you mentioned insurance companies. So before you can sometimes get Dupixent, you have to go through a trial of PPI and a steroid inhaler. And fluticasone inhaler, I used to use that all the time before Dupixent came out, and EOHILIA came out. Obviously the problem with those is that they're actually used for inhalation and not swallowing.
Correct.
So the dosage, you have to do it 4 times a day, 2 doses 4 times a day, or 4 doses twice a day. People can get candida and other infections with it. So it's kind of lost favor. And then using budesonide slurry along with Splenda, we used to use as well too. Just kind of have them swallow it and bathe. It's just cumbersome when you can just take a PPI BID or take Dupixent once a week to get the same effect.
Gotcha.
The 6-food elimination diet, it's 70% effective, and then you can really eliminate those things that really are causing you problems. And that's why every 2 weeks reintroducing a new food will help that to differentiate what is the real culprit here.
Yeah, I think like you said, it was like 60% will find at least one trigger, and if they keep pursuing that diet, sometimes they'll have like another secondary trigger on top of that. So
definitely so. And those are the 6 really allergens that we are exposed to in the GI world.
Do you ever recommend going to an allergist to testing for these types of allergens if it comes to a very severe point?
Yeah, I'll tell you what, it's fraught with not good results, let's say. RAS testing does not work at all on these people. Prick testing can, but it's not very sensitive. We used to send people to the allergist, and then it just wasn't really responsive. So maybe we're sending to the wrong allergist. And hopefully your audience has a different perspective. But I mean, the data doesn't really show that it's really effective in sending people to an allergist. Now, if they have other atopic diseases, of course, if that they can help those, that's fine. But as far as eosinophilic esophagitis goes, it doesn't really help very much. If you're an adult with symptoms where food is sticking inside your esophagus and it's getting worse and worse, and you really don't have any reflux symptoms, and you have other atopic disease, asthma, other allergies, seasonal allergies, and that's the person who we want to see, because you probably have eosinophilic esophagitis. Last thing that you want, and the last thing I want, is to be called in the middle of the night for a esophageal food bowl. So if we can prevent that ahead of time going in, that's always the best. It's always the best. Yeah.
Someone comes in with, just say, GERD reflux, and we start them on PPIs.
Yeah.
When should we say this PPI is not working, or if we add on, say, antihistamine inhibitor on top, and we say, like, hey, something's just not working? When should we kind of think or focus our thought? Maybe, hey, let's backtrack a bit. We're doing EOE here, not really just acid reflux.
Yeah, the usual time course of EOE and PPI is, if you don't respond after 8 weeks, you may have a small caliber esophagus, and it's just not going to get better. You need to go down to the scope and stretch it open. So that would be the main thing. If you have someone who, they got symptoms of dysphagia, they also have reflux, they're on BID PPI for 8 weeks, and they're just not doing as well as you hope, that's when to kind of get in scope. God forbid there's pseudoachalasia, there's other disease states that can cause dysphagia.
Definitely.
Patients have had long-standing reflux disease and they develop Barrett's esophagus, esophageal adenocarcinoma. Usually those people have weight loss.
Mm-hmm.
Interesting. So one thing we didn't talk about, I apologize. One thing we didn't talk about is some people, and this may be part of your audience too, is that some people will also change their diet. They do these what we call adaptive behaviors. Like they will eat a steak. They'll kind of either ground it down, get ground beef out of it, but they won't eat something that they know is going to get stuck. So they really adapt their behavior. They drink a lot of water. They cut their food into real tiny little bites, because they have that experience of, man, if I eat that piece of chicken or that steak, it's going to get stuck, or it's going to get stuck, and it's going to be so much chest pain. So they adapt their lifestyle. There's some acronym for that. It's like drinking so much water, cutting your food up in little pieces of time, taking time, remaining upright. So when the person comes in and you're like, how's your swallowing? Oh, it's great. Well, then you have to ask the other question is, how small are your little pieces? Are you adapting your behavior because of this EOE, or is it because things are getting better? But if they start cutting your steaks into little pieces, drinking a lot of fluid, remaining upright, then they're adapting your lifestyle, and eventually it's just going to have
it's getting smaller. Funny you mentioned that, is I actually saw a patient a few weeks ago, the same thing, but instead of food, how I kind of pinpointed was she's like, I can't take this medication. I can't remember what it was potassium. And she's like, yeah, these pills are like horse pills. She's like, I can't swallow it. So I break it in pieces. And then it's just like, and I started asking her, I don't know how it led to, but I started asking her a question. I was like, hey, it's like, I don't take these, I don't eat that. And I was like, do you have a problem swallowing? She's like, no, I don't have a problem swallowing. It's like, I just but certain things can make it difficult for me. So I just cut very small pieces, or, and I just eat everything ground, like you said. And I'm just like, that's not normal.
Exactly, yeah. It's normal to them.
Correct.
They do it for such a long period of time. But it's not normal for you and I, where we just bang down a hamburger without a problem. But they would never do that.
So keep in mind, for any type of EOE symptoms, this is more of a podcast just to kind of discuss about the topic and spread awareness and education. If you need medical attention, please seek your primary provider or proceed to the emergency department, especially if you have a food bolus like that as well.
Yeah.
Actually, let's do that again. We'll put that as the thumbnail.